Those of you who have a Gleason score of 7, 8, or 9, you do not have the choice of doing active surveillance. You need to make a choice and do something soon. You don't need to do it tomorrow, but you do need to be making efforts to make a timely decision to get treated, because depending upon how aggressive the prostate cancer is, you don't want to have a situation where it gets outside the prostate. That's a much worse situation to deal with. In trying to make the determination of whether or not the prostate cancer is organ confined, there's actually 3 different measures that you want to look at. Gleason score, your PSA level, and something we haven't talked about before, which is clinical stage. The doctors generally talk in terms of diseases in terms of T1, T2, T3, and T4 as different measures of severity, with T3 and T4 being the worst. Most prostate cancer patients fall in the T1, T2 area. With the data on your clinical stage and your Gleason score and your PSA, by using the Parton tables, which is something developed at Johns Hopkins University and involving over 5,000 men, they have a statistical database that helps you determine whether or not the prostate cancer has gotten beyond the organ, whether or not there's extracapsular expansion, whether or not there is involvement in the lymph nodes, and whether or not the seminal vesicles have been involved with prostate cancer. When you get that data with your physician, you can then start to make a determination that you look like, or you don't look like, an excellent candidate for surgery. There are 2 major types of surgery. There is the anatomic retropubic radical prostatectomy, which is generally referred to as open surgery. Surgeons come in and make incisions in your pubic area and go down and remove the prostate. And this is a procedure that's been done for decades. More recently, there has been introduced laparoscopic surgery to do the same thing, and it's referred to as laparoscopic radical prostatectomy. The newest, latest, greatest is the laparoscopic robotic. It's generally referred to as the Da Vinci system. When you actually look at the data, there have been about 5,000 men who have undergone the robotic system. The outcomes from the first 5,000 seem to indicate that although there's a lot of hype associated with the robotic, in fact, the outcomes look quite similar. It obviously depends on the institution, it depends on the surgeon, it depends on the severity of the patients that the surgeons are operating on. So there's a lot of variables here, but when you look at the peer-reviewed journal articles, it's not clear that the robotic system at this juncture is doing any better than the open system. And one of the things that I think you do need to take into consideration when you're choosing a surgeon is how many procedures have they done, how comfortable are you with the approach, do you and that individual have a rapport that you understand really what's going to be happening, and that you can jointly sort of share the decision about what's going to be done. Because at the end, this is your choice. Now, if you have a situation where you may have some additional comorbidities, other diseases, you may be older, more frail condition, there are reasons why, even though if the cancer is prostate confined, you may still need to be considering radiation. And that's simply because the surgery takes a lot out of you. I had surgery. It does take some amount of time to come back. If you've got an individual with a heart condition, I think the doctors and the patient may readily conclude that a severe surgery, which prostate cancer surgery is something that is best avoided. That's, again, something you and your physician need to decide. But if we now are in the realm of talking about radiation, there's quite a number of different options all underneath radiation. And it really comes down to the kind of equipment that the hospital and the oncologist that you're working with is employing. But essentially, there's three major definitions of radiation therapy. There is the intensity modulated radiation therapy, where instead of coming in with an external beam that is all one force, you're actually using different intensity at different areas of the prostate cancer. The image-guided radiation therapy is yet another issue where, again, they're trying to come in and actually hit the prostate exactly where the cancer is and to do as little collateral damage as possible to the other surrounding area. A third radiation technology that's just been recently developed is proton beam. And proton beam, unlike IMRT and IGRT that use electromagnetic waves, it's actually using charged particles. Proton beams is essentially depth charges that get dropped to exactly where they believe the prostate cancer is, and it's a new treatment. There's several thousand men that have undergone this experience. The data is preliminary. There's not a lot of 10-year data because of the newness of the procedure. What the initial results seem to indicate is that it's as good as the conventional approach. There's some argument there's fewer side effects, but I would say there's insufficient data as of today to say that proton beam is dramatically better than the conventional radiation therapy. Under radiation therapy, there's also an additional category which is referred to as brachytherapy, and brachytherapy entails inserting radioactive seeds into the prostate, and the benefit of the brachytherapy is that this is a one-time procedure. The IMRT, the proton beam, the IGRT, all of those tend to be of 8 to 9 weeks duration, where you are actually getting radiation 5 times a week for the 8 or 9 weeks. Radiation therapy is a much longer treatment regimen than surgery, but when you take into account the recovery time from the surgery, I think you're best to make your choice on the basis of what you think the best outcomes are going to be. So this has been a very short video. We obviously can't get done everything that we need to get done. Prostate cancer is a difficult disease, but we would hope that you don't make it worse by trying to do everything alone. There's a great band of brothers, of men that have gone out in front of you who have had to address the same journey that you're just now starting. We've learned a lot. We would like to share what we've learned to save you some of the frustrations and aggravations that we've had. I'd ask that you come into the website www.mcfpc.org and try to link up and find a support group in your area. Or if you're not comfortable with a support group, come in, contact us, contact me, and we'll try to put you together with one gentleman on a one-to-one basis. It's completely confidential. They'll try to answer any and every one of your questions. We're here to help. That's what we're trying to do. We know how difficult the journey is that you're on. We're here to try to help make it easy.